Good evening, everyone. Thank you for being here tonight for our webcast, Behavioral Pharmacology in Shelter Settings. I'm Jessie Guglielmo, Education Specialist with Maddie's Fund. Our speaker tonight is Dr. Sara Bennett. Dr. Bennett received her doctorate of veterinary medicine as well as her residency in animal behavior from the University of Purdue. Then in 2012, Dr. Bennett received her certification as a diplomat of the American College of Veterinary Behaviorists. She is currently a courtesy lecturer and co-instructor at the University of Florida College of Veterinary Medicine, Maddie's Shelter Medicine program, teaching classes such as shelter animal behavior and welfare. Dr. Bennett also performs behavior consultations, where she addresses a variety of behavior problems and behavior disorders. Before we start, let's talk about a few housekeeping items. Please take a look at the left side of your screen where you'll see a Q&A window. That's where you'll ask questions during the presentation. Please get your questions in early, as questions submitted late in the presentation may not be processed in time for a response. If you wish to review this presentation or see other helpful handouts regarding this topic, you can find a PDF version of this presentation in the resource widget at the bottom of your screen. If you need help with your connection during the presentation, you can click the Help widget at the bottom of your screen as well. This presentation will be available on demand within 24 hours should you wish to view it again. Dr. Bennett, thank you for being here tonight.
Thank you very much for having me. I'm very excited to be talking to this group about how we can use behavior medications to help those pets that are in sheltered settings. And so with that, we'll go ahead and get started with a poll question.
Thank you, Sara. So here's our first poll question. How many of you use behavior medications in shelter or rescue patients? Now please answer on your screen and not in the Q&A window. I'll give you a couple seconds here to answer. Okay, and let's see what you guys answered. All right, Dr. Bennett, what do you think about this?
I think that is fantastic. That means that I am talking to the right audience. You're open to the idea and you're wanting to learn more, so fantastic. So let's go ahead and move on. What I'd like to talk about today is give you a little bit more information about what we'll be looking at when we want to consider prescribing medications for behavior problems. We'll talk about the unique situation that shelter animals can present when we have to look at things like monitoring, how we might go about that and delegating that, and also looking at medication choices in terms of what might be most suitable for a pet in a shelter setting. And lastly, we'll make sure we wrap up with talking a little bit more about what to think about when we're looking at outcome options for these patients and how the medications, they play a role in how we plan their outcome and their path out of the shelter. So to get started with, let's review some of the reasons that we might consider using behavior medications for dogs that are in shelters or rescue groups. The two most common themes that we'll continue to follow back on are going to be, one, to address an immediate welfare concern, and this can actually help facilitate improving the adoption prospects for that pet, help smooth the transition the pet has into a new home after adoption, and it also may help reduce the amount of time that treatment is needed for the behavior problem that is causing a concern. Secondly, we may be looking at treating a pet who has a already established behavior disorder, so a true behavior pathology. Of course, this is going to help improve welfare for that pet in the short term and the long term, because most of these problems are things that we're going to be managing for this pet. It may help a pet who may be less desirable as an adoption candidate become more appealing to the community, and it also may help to keep that pet as a successful member of that home long term. So when we're looking at medications, there are some guidelines and goals that we want to consider when we're choosing our medications and our cases for this. And these are going to be the same whether we're dealing with a pet who's in a shelter or a pet who's in an owned home. Really, when we're looking at behavior medications, remember, what we want to do is we want to address the underlying neurotransmitter alteration that we think is present that is causing or contributing to the behavior problem that we're seeing the pet display. Along those lines, what we can see when we address that neurotransmitter alteration is a decrease in reactivity. So the pet's intensity of reaction might be a little less high. If they do get to that point, maybe it takes them just a little bit longer to get there. And when they do get there, maybe it takes them just a little less time to actually come back down to baseline. And this actually makes behavior modification and successive environmental modification a little bit easier and less stressful on everybody to implement. And that can be really, really important when we're looking at maintaining buy-in from our staff, volunteers, foster base, and even new adopters. But remember, the medications aren't going to change the actual behavior pattern that the pet is displaying, because oftentimes those behavior patterns that they are showing are a consequence of learning, and so it's a coping strategy for that situation. And the pet may not necessarily be coping well, but it's something that they're trying. So we really are looking at changing the emotional state associated with that, and that gives us a window of opportunity to use behavior modification to change the behavior pattern. So when we're looking at prescribing, a couple of things that we want to consider, particularly when we're looking at shelter and rescue pets, and this is going to be a little bit differently than what we would see if we were working with a privately owned pet, are looking at things like risk assessments. And I actually do a risk assessment for every single one of my patients, whether they be privately owned or whether they be in a sheltering organization. But certainly we need to keep in mind the resources that the shelter has at their disposal, as well as the community that the shelter is trying to serve when we're trying to decide if a medication is a suitable adjunct to our treatment plan, and also what medication we might choose. So going back to a risk assessment, we want to think about safety, of course. We want to think about safety to the patient. We want to think about the safety of the other animals around that pet, as well as the people around it. And I'm not talking about just physical safety, so bite risks, escape risks, self-injury, things like that. I'm also talking about the emotional risk, because sometimes that can be just as challenging to manage long-term as is the physical risk. You know, they're putting a lot of effort and emotional drive into treating these problems and managing them, and that can really have a long impact on how that owner feels, or the staff even feel about dealing with those types of problems, as well as, you know, whether they're doing the right thing. Along with that, of course, goes quality of life. As you can imagine, with the emotional risk side of this, we want to make sure that we're improving everybody's quality of life, right? The goal is to have a life worth living, or a life that is enjoyable. And again, this needs to be for the pet and for the person. That should be our goal. And this isn't something that is static. It can change over time, so it is something that we need to be prepared to reevaluate at regular intervals. The other thing that we need to consider is, what's the risk of allowing that pet to continue to deteriorate? What happens if we wait? You know, can that pet get to the point where the problem is so bad that it's dangerous, or the welfare is so compromised that there isn't a good prospect of recovering, or it's not okay to continue living in that state? And it's not acceptable to keep a pet in a situation where we can't make improvement and deterioration is inevitable for the sake of keeping the pet alive. You know, that is something I think that comes up a lot in terms of, well, we're keeping the pet alive, but if their life is absolutely miserable because their welfare is suffering and their quality of life is at that point where it is unacceptable, we need to be making a decision based on the best interest for that pet. And again, when we're thinking about these quality of life and safety and risk assessments, we're really looking at the same considerations that we would look at if we're trying to determine an Asilomar classification for a particular problem in our community, right? You know, do we have the resources to address these problems that we're facing right now? Whether that be, you know, does the community have, is this realistic for our community to take on? And if so, do we have, you know, the resources in our shelter to try to address it while the pet is still within our care? So, moving into shelter's resources, can this organization manage the problem, right? We have to think about what they have available to help that pet, and we have to think about this from a manpower standpoint, time, education, money. All of these are going to be finite resources for a sheltering organization that we need to consider. And not all organizations are going to be able to manage every problem. We also need to consider the community that this pet is going to be going into. Is this something the community is willing to take on? Again, going back to that Asilomar classification, this is a great place to use the Asilomar accord so that we have an idea in terms of what our community can and cannot or is willing to take on. And the other thing to consider, too, is the perception of the community about behavior medication. And these two things are really going to vary quite a bit based on the demographic that your community serves as well as the geographic area that you're in. I've got a couple of case examples of how things are so different, from seeing cases in Chicago versus, doing some courses in Boston and even working a little bit with a couple of groups in Austin, Texas. And the community perceptions that are so different between those areas that we have to consider. We're moving into when we want to prescribe. And again, some of this is going to be quite similar to what we would expect for any patient, whether privately owned or in a sheltering system, and whether we're dealing with a, excuse me, a medical problem or a behavior problem. And we're going to talk about each of these. We need to make sure that we have a valid client-patient relationship, however your state may choose to define what that looks like. Each pet does need to have a medical evaluation ahead of time so that we can make sure we're doing our due diligence and ruling out any medical components that could be adding to or contributing to the behavior problems we're seeing. We need to at least have a working diagnosis. We may not have enough information to have a final diagnosis yet, but we need to at least have a diagnostic list and a working diagnosis to base our plan off of. We always need to consider other treatments that we can implement. Remember, medication in and of itself isn't going to solve the problem. Very, very, very rarely is that going to be the only portion of our treatment plan. And so we need to make sure that we are looking at all aspects of this. And medication is really just a tool in our toolbox that we can add to our treatment plan to help make it more successful, more comprehensive. Lab work is another one that we want to think about. In a perfect world, we would have pre-medication lab work on every patient before we started behavior medication for them. But I know it's not a perfect world, and resources are limited. I have to keep in mind that majority of the patients that I am treating in a shelter setting are going to be otherwise normal, healthy young adult animals. And so oftentimes we have to look at the risk versus benefit of doing lab work and the costs incurred with that versus the information that we're going to gain. And though I may strongly encourage my privately owned clients to have lab work done on their pets prior to starting medication, this is not a situation in a shelter where I'm not going to prescribe medication for a pet who is experiencing a welfare emergency because the shelter doesn't have the resources to do pre-medication lab work on that otherwise healthy pet. So again, there may be some situations where it is indicated for us to do that lab work, but that is certainly not a set-in-stone requirement for this. But what is set-in-stone requirement for this is a follow-up plan. If we're going to be using medications, we need to make sure that we have a plan on how we're going to reassess that animal at a specific time point so we can tell whether or not our plan is actually working or not. Do we need to change something, whether it be the medications or other aspects of the plan? So that needs to be written in with our plan, with the rest of our treatment when we start using medications for behavior. All right. And along with our follow-up, we have to think about outcomes, right? And so I live my life by this motto: plan for the worst and hope for the best. Always have a plan B, right? Always have a backup plan. What happens if? Then you have a contingency to fall upon. And again, this is the same thing that we often do when we're in private practice, right? We recommend the ideal plan first, but if that's not feasible, it's not realistic for the situation, then we give our second option, right? So remember the consequences for no plan B for a shelter pet, right? It's not really fair to them for the only options to be adopt or die, right? So we have to look at other outcome options, think outside the box, look at our networks and our resources available to us and see if there's other things that we could potentially do to help this pet, whether it be treatment within our organization or if it's transferred to another organization that could potentially help that pet. All right, so let's move on to monitoring. And what do we do once we've prescribed our medications for our pets, and how is this different than what we might expect from a private setting? So, two things that I want to think of, and you'll keep seeing common themes popping up here. So I like to have a designated person. I love to delegate, so this is something that I will make sure I have a point person to work with. And also, we want to make sure that we have a follow-up plan. Remember, we talked about that being part of our treatment strategy when we were writing up our plan for our pets. When we're thinking about outcome, we also want to think about what's happening after the outcome occurs. So adoption versus transfer, what's our plan for our medications? We'll talk a little bit more about that later on in the presentation. But for now, let's talk about what we might consider for our designated point person. So questions you might want to consider when we're thinking about using medication for a behavior problem is there a veterinarian at the shelter daily? Or is there a technician? You know, for example, in my situation, I consult with many shelters. I'm not at those shelters every single day, so I need to have a point person who's on the ground that I can rely on to be checking on that patient on a regular basis. So I look for the veterinarian or the technician or a handler or caregiver that I can get direct access to. We want to know whether or not there's being rounds performed and who's doing them. You know, of course, with the perfect world, everybody would be doing daily rounds on every patient, every pet in their care. Again, I know it's not a perfect world, and we all strive towards that goal, but we don't get there. We want to make sure that we've got things like appetite and water intake, urination and defecation being monitored on a regular basis, because these are some things that could change as a consequence of our behavior medication. So we want to know if there's side effects occurring. The level of activity is going to be another one, too. This can be an indication of a side effect, or it could be an indication of our treatment working. Level of undesired behavior, so the behavior that is considered a problem, is it staying the same? Is it increasing, or is it decreasing? And what about the level of anxiety? How are they perceiving the pet's level of anxiety? What type of stress behaviors are they seeing? How frequent are they? How intense are they? And this can be done with a fairly straightforward check sheet that staff can go through and mark as they go through and care for the animals too. So we don't have to make this a huge complex process, and we've got different ways that we can get this to happen. But the point of this is that we have to have a plan on how we want monitoring to occur. And again, along with that, knowing who our designated person is, we want to know when we're going to touch bases with them, right? So when do you want to hear back from your point person on how things are going? Do they know who to contact and how, right? Do they have your email and phone number for that? Do they know what to watch for? What side effects are they going to be looking out for in that pet? How are they going to know whether things are going well or not going well? And that gives us the opportunity to say, well, let's talk in a week. Let's talk in 2 weeks, and then let's see this pet again in 4 weeks down the road, and if the pet is still there. And then reassess our plan and adjust based on what we're seeing, right? And we can always adjust that based on the individual pet's needs. And along with that, too, is that we have to have a plan that goes with the pet, right? And so one of the things that I strive to do is to make sure that whatever plan that I put into place for that pet, when it's under the care of that organization, that plan goes with that pet wherever that pet goes. So it becomes part of the medical record and follows that pet to every step of its journey to its final home. That way everybody is on the same page in terms of knowing what has already happened and what's currently being implemented to help that pet. So before we go into our medications, I want to have a very, very brief review of the neurotransmitters that we are trying to impact with our medications. And I promise this will be brief, and I hope that I don't put anybody to sleep or scare you with this. I promise it will be relatively painless. We'll go through that, but that will give us a better basis to understand how our medications are going to work and how we might want to choose specific ones. All right. So really when I'm talking about neurotransmitters, remember these are really just chemical messengers, right? The big ones that we're going to be talking about today are going to be glutamate, GABA, acetylcholine, and then the monoamines such as dopamine, norepinephrine, and noradrenaline, and serotonin. And you'll see their abbreviations next to each name there. And so it's going to be a little bit of a wild ride to Chicago, but we've got enough gas and cigarettes to get us there, and we're cool enough to wear sunglasses and fedoras. So let's do it. So starting with glutamate, this is essentially an amino acid that acts as a neurotransmitter. It's the major excitatory neurotransmitter in the brain, and a majority of the brain is going to actually use this for its functioning. In people, we know that we can have abnormal levels of this particular neurotransmitter in some type of psychiatric disorders such as schizophrenic disorders or aggressive problems or impulsivity. So we don't have that level of understanding in pets, but certainly a lot of this gets extrapolated from human psychology. On the flip side of that is GABA. So glutamate and GABA kind of work opposite of each other. So remember, glutamate is a major excitatory neurotransmitter, and GABA is the major inhibitory neurotransmitter. It's actually synthesized from glutamate, and you'll see this pattern kind of following through some of the neurotransmitters we talk about. But it has specific roles when we're thinking about vigilance, anxiety, muscle tension, seizure activity, and memory. And this makes sense when we think about the medications used to address GABA. Oftentimes we are trying to control seizure activity or to reduce anxiety or use them as muscle relaxants. So it makes sense that what this neurotransmitter does is what we're trying to impact with our medication. Going on to acetylcholine, I think a lot of us are more familiar with acetylcholine from myasthenia gravis, but it can also be present in a lot of other areas. Particularly, we can see acetylcholine being implicated, particularly with neurodegenerative diseases such as dementia or Alzheimer's type problems. And this is going to be our only neurotransmitter that's not actually synthesized from an amino acid. It's actually made from choline and acetyl-CoA. So if you want to remember way back to early physiology from vet school, talking about how this was put together. And acetylcholine works in many, many different areas of the body. So remember, we've got muscarinic receptors for acetylcholine, and those are going to be our parasympathetic synapses. We've got the nicotinic in receptors, and that's going to be our autonomic nervous system, right, and our adrenal medulla. And then, of course, we have our neuromuscular junctions, or the nicotinic M receptors, and that's what we remember being affected with myasthenia gravis, right? But again, thinking about this from a psychological standpoint, we're really more interested in what it does with learning and memory and how it activates the reward systems and dependence such as addiction and things like that. Moving into the monoamines, we're going to be looking at a couple of the catecholamines, and we'll also be looking at our big player, serotonin. And so you'll see some of these you might not be expecting to pop up into our neurotransmitter categories like melatonin and histamine, but it's important to remember that those can have a role there too. So looking at the catecholamines, remember that there would be a pattern in terms of how things are synthesized. And dopamine and norepinephrine play the same rules as glutamate and GABA do. So they actually are both made from the same amino acid, and norepinephrine is actually made from dopamine, but only specific cells have the enzyme to take that next step to make dopamine into norepinephrine. When we're thinking about dopamine, I try to color code neurotransmitters so it's easier for me to remember. And so I think of dopamine as black because it has a high concentration in the substantia nigra of the brain. And we're going to see dopamine being a player when we're thinking about things like phenothiazines, like perhaps acepromazine. Our monoamine oxidase inhibitors, so we think about things like amitraz or selegiline, which is labeled for cognitive dysfunction in dogs, and even some of our natural rewards, right? So food, sex, things like that. With norepinephrine, remember we have specific cells that can make that from dopamine. And we'll have our alpha and beta adrenergic sites for that. And this can be a complicated one because it can have agonist or antagonist activity depending on whether it's acting at a pre- or post-synaptic receptor. So sometimes the mechanism of action of the medications that affect norepinephrine can get a little complicated, but don't lose hope. Generally, we can get it squared away. But I think about norepinephrine as the blue neurotransmitter, and that's because it's mainly concentrated in the locus coeruleus of the brain, which actually has a little bit of a blue tinge. And moving into our last one, and I told you this would be hopefully relatively painless, and not put you to sleep, we're going to talk about serotonin. This is actually made from the amino acid tryptophan. We all know tryptophan from getting sleepy after we eat our turkey for Thanksgiving, coming up in a couple of weeks here. But the interesting thing is you look through the process of how that is made, you'll see serotonin on there, and then you see melatonin. And melatonin is actually synthesized from serotonin in specific parts of the brain. And so we have to remember that when we're doing supplements. Sometimes supplements are not nearly as inert as we would like to think. They can actually impact some other neurotransmitters based on relative concentration in the brain. So don't forget that part. Serotonin is concentrated in the midbrain, the graphite of the midbrain, and it actually has receptors in the entire body. Many, many different cell types are going to be impacted by serotonin. And this is important for us to remember when we're thinking about side effects, because we use serotonin-directed medications quite a bit for behavior. So I'm going to show you a little table here that'll give you an idea of what we're talking about with these different types of receptors. And so, you'll see serotonin 1A, 1B, 2A, so on and so forth. And you'll see things like platelet aggregation and heart valves and appetite and nausea and vomiting. So this is where we see our side effects, right? The most common side effects of most of our serotonergic medications are going to be GI related, right? Decrease in appetite or maybe a little bit of nausea. And we can use some of these depending on whether they're activating or inhibiting to our advantage based on the side effects. We'll talk about that in a little bit. So it's not just working on the brain, it's working on a lot of different parts of the body. Okay, moving on off of our neurotransmitter whirlwind there, we'll talk a little bit more about medication choices. So remember, what's our goal? Our goal was to address the neurotransmitter abnormality that we thought was underlying our behavior problem. So two specific goals that we may see in the shelter are going to be, do we have an immediate problem? So something like kennel stress, where we need to do something now because this pet's welfare is compromised. We might look at a short onset medication, something that's going to take effect quickly. And so things that fall into that category are going to be our benzodiazepines, something like trazodone, clonidine, or gabapentin. Or maybe we anticipate there's going to be longer-term management needed. So maybe this pet came into the shelter with a behavior disorder. Maybe he was diagnosed with compulsive disorder or separation anxiety, and that was part of the reason that got him turned into the shelter. All is not lost on that pet. We could potentially be able to rehome him into an appropriate home, but it's likely that he's going to need some type of behavioral support long-term, even in that new home. And this is where we may want to use a medication that's going to have a longer duration or chronic control over his anxiety. Or perhaps those pets with an anticipated long-term stay, right? The slow movers. This is another place where we may want to use this. So, do we have significant or frequent fears? We can't manage the environment or generalized anxiety going on. And so classes of medication that we think about for these are going to be things like our SSRIs, our TCAs, and our zaparones. And that actually brings us to our next poll question.
Okay, thank you, Dr. Bennett. Our second poll question is, what do you think? Okay, and your answers are A, behavior complaints in shelter pets are purely a consequence of the stressful environment. B, sheltered pets with behavior complaints have an underlying behavior disorder and come into the shelter already damaged. Or C, we are dealing with two different populations. The behavior complaints are a consequence of both above. remember to answer on your screen and not in the Q&A box. And I also want to remind everybody that if you have any questions for Dr. Bennett, we will be answering some questions at the end of this presentation. So make sure to get your questions in early through the Q&A box so that we have enough time to process them and answer them at the end. All right, I'm going to be going on to the answer slide. Okay, and we have a unanimous answer, Dr. Bennett.
Fantastic. I was going to try to catch some people with my trick question, and you guys all saw through it. Great job, guys. You're right. I think we are dealing with two different populations, right? We have pets who have something wrong, and it's going to stay with them regardless of the environment that they're in. And then we have pets who are really struggling with the environment itself, right? And the problem that they're dealing with is purely due to the environment and their surroundings. Great job, guys. All right, so let's talk a little bit then about medication choices. So we've got everybody here who is enthusiastic about the potential for using behavior meds in shelter pets, or at least willing to dip their toe in the water. So this is where we're going to pay attention to what might be the best options for us. So globally speaking, before we get to the actual medications themselves, let's think a little bit more about resources and how that might affect which medication we'll choose. We want to think about how we have to administer it. You know, how frequently does it need to be dosed? Does that organization have enough people, enough manpower to give that medication twice a day, 3 times a day? I would say even for my very well-resourced shelters, asking them to do more than twice a day medication is really, really challenging. I think it's challenging for anyone, even a privately owned pet or a private owner, to do that frequent. So we have to think about that because it's going to impact our compliance, right? And how well that part of our treatment plan is going to be utilized. How do we give that to the pet? You know, most of the medications we're using are oral. How easy is it to get this medication into that pet? You know, if they're showing aggression because they're frightened, we may not necessarily want to have the staff have to pill the pet. You know, is there a way for us to sneak it in, right? Can we mix it in a little bit of food, use something like a pill pocket or a pill paste, peanut butter, cheese, you know, whatever, you know, part of someone's leftover sandwich from lunch? You know, what's our plan? We need to have a plan A and a plan B for administration for these guys. And then we also have to think about how difficult is that administration going to be? And are we actually doing more harm than good by adding the stress of administration to that pet? So I always think about cats, particularly in these situations, you know, those really, really high-stress cats that are going to start lashing out because they feel like their life is in danger, and we're trying to give them a pill. And, of course, we all know cats are notorious for not being very cooperative when it comes to giving tablets and things like that. So are we actually making things worse by having this unpleasant interaction with a caregiver, by trying to shove this pill down this poor cat's throat, than if we just let the cat alone? Sometimes we have to do a risk versus benefit balance on these as well, and sometimes maybe it's better to not do the medication or look for something that we don't have to administer in that route, what's easier for them. So keep that in mind. The other things we have to think about when we're looking at shelter resources is cost and availability, right? Money and time tend to be the most limiting factors for most organizations. You know, obviously they're not-for-profit, most of them, and donations and grants are going to be an important part of their income, so I don't want to waste their money. So I'm going to be looking for medications that are going to be lower cost for them and are easy for them to get, right? Looking for something that they can get through their distributors rather than having to go through an outside pharmacy or compounding. And then also the abuse potential, right? You know, we have to think about this, you know, particularly with the benzodiazepines and some of the other medications. Is there risk for diversion? You know, if you're not there, you're the one taking it out of the lockbox and administering it to the patient. Who has access to that? And again, this is something that's a risk sensitivity issue in terms of that shelter's comfort level as well as your own, knowing that you would be the one prescribing on how you want to manage that and whether it's a situation that you're comfortable using a controlled substance. Legal constraints can also play a role, and this is going to really vary widely depending on where you are also, your community. I think a lot about dogs and cats that are under rabies observation. You know, they've got that 10-day quarantine hold, and obviously that can be extremely stressful for those pets to endure. And a lot of times they're on that rabies observation hold because they had some type of behavior display that was, you know, not necessarily appropriate for our society, right? So can we use medication to help minimize the trauma and the stress associated with that quarantine period? Sometimes we can, sometimes we cannot. It really depends on the jurisdiction. The most frequent concern that I get confronted with when I'm having this discussion is the concern that potentially side effects for these medications could mimic neurologic changes. And so they're worried about muddying the waters when we're trying to observe a pet for signs of rabies. I think we can mitigate that by being aware of what medications that we choose, and also having a diplomatic discussion with the person who has that concern about the relative risk of side effects and what we would do if perhaps we would see something like that. Another one to think about are court-ordered holds, so those dogs that are being under confiscation or being held as evidence. But one of the things that we have to remind those that are involved in these cases is that our requirement is to hold this evidence, right? These animals are evidence in a manner to prevent deterioration. And so generally people assume that that means physical health, but it does also include mental health. And so we can actually make a case for some of these pets that their mental health is going to deteriorate from these long lengths of stay in these relatively confined quarters because they're not able to have that same level of enrichment that a lot of the other pets in our care could have. And so medications is another tool that we can potentially use to help mitigate some of that damage. And this is certainly a welfare concern for a lot of these pets. So don't be afraid to sit down and have a discussion with the officers and other folks that are involved in these cases to see if we can't do something to help that pet's welfare. All right, now we go back to medications. I show this picture. One, it's impressive, right? We're looking through a door. But two, because this is actually one of my shelter organization's pets. So this was actually Buddy. He was a golden retriever, who they had been working on managing his separation anxiety and noise phobia through a variety of foster homes, and were working on trying to get him to an adoptive home. Clearly at this point we had a setback, and he actually ate through the door. So we needed to do something for poor Buddy. We needed to do it fast. So this is our nice segue into talking a little bit more about some of those fast-acting medications. Those immediate welfare concerns are who we're addressing right now. You're going to get a couple of tables with a lot of different medications listed, as well as doses and side effects and things like that. So don't despair. I think you guys will have access to these notes and these slides. You can have these tables for reference. So remember, when we're talking about the fast-acting medications, we're going to think about the benzodiazepines. There's a ton of them out there. My general rule is pick two and get comfortable with them, and then we can branch out from there. So most of the time, those two that we pick are going to be helpful for a majority of our patients, and we don't have to branch out beyond that very often. So the two that I'm most comfortable with personally, because I've used them the most, are clonazepam and alprazolam. And you can see the dose ranges for those medications are quite large. As expected with benzodiazepines, sedation and hypotension, certainly are concerns at higher doses. We could potentially have paradoxical excitations. Those side effects really go with both of those. And also, relatively speaking, these are two that are going to have perhaps a little bit longer duration of action than something like Valium might have in our dogs and cats. So these would be ones that I'd be more inclined to use for managing a behavior problem. But still might be a little challenging to use to manage a frequently occurring situation if we had to dose 3 times a day. And another thing to think about, most of these medications that we're going to be talking about for the short-acting immediate control, is that when we're looking at doses, you'll see a lot of these have huge doses. And we're going to hit the dose of anxiety control before we will hit the dose of sedation. So generally when I'm talking to folks about using these and trialing doses, we start low and we work our way up. And if we've gotten to the point where the pet seems sedate and it's not helping the anxiety, then this medication is probably not the medication of choice for that particular pet, and we need to try a different one. Because by that point we have surpassed that point where we would expect anxiety control to occur. So keep that in mind when you're talking to your caregivers about using these. Trazodone is one that's becoming much more popular. This is an atypical antidepressant. It works at the level of serotonin, but works a little bit different than our SSRIs like Prozac and things like that. I really like it because it's a very versatile medication for us, and it's also not controlled. And so again, you can see a huge dose range there. Generally, we'll start low and work our way up. Most of the time, I only have to dose it twice a day, which is feasible for most of the shelters that I work with. And side effects are generally mild to non-existent. We might see a little bit of sedation initially. That generally goes away quite quickly and tends to be dose dependent, and maybe a little bit of stomach upset. And most of the shelters I work with, perhaps not the foster homes, but the shelters at least, tend to be a little bit more forgiving about a bout of diarrhea than a family home would be. So keep that in mind as well. But I actually use that quite a bit because I'm not in these shelters every day, and I'm relying on someone else to manage these medications. I don't use benzodiazepines very often, but I do use trazodone quite frequently. And I've had very good effect with it. Continuing on our fast-acting immediate anxiety control, clonidine is another medication that we can consider. This is one that's going to work at the level of norepinephrine. And so if I'm thinking about a pet who is having a high arousal aspect to his anxiety, so that really active, agitated anxiety, I might think about clonidine as a choice for him. And again, huge dose range on there, but that decimal point is very, very important. And again, sedation, perhaps the higher doses, theoretically, because this is a medication that was historically used to control blood pressure in people, we could potentially give them a high enough dose to hit hypotension. But this is going to be very, very unlikely to occur, particularly at the doses that we're using within this dose range. One of the shortcomings of clonidine is that the duration is a little bit shorter. And so oftentimes we're not going to see this last for more than 6 hours, sometimes up to 8 if we're lucky. So this is something that we're going to have to dose for a situation. So those pets that are really stressed out when they go on their walks, their daily walks, we can dose it ahead of time. Or if we're having specific events that are going to occur, like a noise event or something like that. But that can be very helpful, too, if we think that there's a high arousal aspect to this. Gabapentin is one that I have been using more and more. Remember, this has historically been used as a medication for anticonvulsant or also neuropathic pain, right? My dose range for anxiety control is actually the same that you'll see for pain control, so 10 to 30 milligrams per kilogram. Side effects, again, are minimal, maybe some sedation early on or at the higher doses. Oftentimes I can get away with dosing this every 12 hours or twice a day for those pets that are sheltered. And I have found this has been a really, really excellent option for us to use for cats in particular. Remember, don't use the liquid human formulation of gabapentin because it can have an artificial sweetener in it that can be toxic. If you have it compounded into a liquid and you have a conversation with your compounding pharmacy about what they're using for their carrier, but don't use the human formulation of that. But this can be really helpful, and you can, break open the capsules and mix it in a little bit of canned food. You can mix it into a little bit of a liquid or broth and give it by syringe if it tastes pretty good. Most of the time we can hide this so it's not too bad, and this can be really helpful, particularly if we think there might be a pain component to the anxiety. So I think about those pets who might have underlying arthritis or diabetics with neuropathy, or just those older pets who have poor muscle condition and are expected to live in a less than comfortable surface than perhaps they were used to in their previous home. You'll see that acepromazine is also on this list. Remember, we talked about acepromazine briefly when we were talking about dopamine. Couple of things about acepromazine, though. I want to get on my soapbox for just a second here with you. I promise it will be fast. But remember that acepromazine is a tranquilizer, right? It's not a anxiolytic or a sedative. So it really doesn't have any impact on the anxiety level of the pet. What happens is that we can stop the physical reaction to the trigger for the pet. So, for example, that pet who has that reaction to noise or being left alone, we can stop them from running through the door or eating a hole in the door like poor Buddy did. But we're actually not doing anything other than just stopping his physical motion. So if you think about that nightmare that you've had where you're trying to run away from something chasing you in your dream, but your body is either frozen or moving in slow motion, that's essentially the state that we're putting these pets in when we give them acepromazine to address a situation that causes fear for them. They're conscious. If they're not completely unconscious, they are aware that the trigger is still there. They just can't do anything about it. So that may actually be a pretty traumatizing state to put that pet in, and it can actually increase sensitivity to noise. I think we've probably all seen that when a pet has had a pre-anesthetic dose of acepromazine and we thought he was pretty sleepy, and then someone dropped a metal pan or something like that and he jumped off the table, right? So acepromazine can be a really, really helpful medication, and it certainly has its role in veterinary medicine, but I don't think the role is necessarily in management of behavior problems, particularly those that have a fear component, and especially those that have a noise component. So this is absolutely, at this point, considered inappropriate to use alone to manage noise aversions. Okay, I'm going to jump off my soapbox and back to medications. So let's talk a little bit more about the short-acting medications, and these tables are going to be for cats. So essentially they're going to look very similar to what we just went through for the dogs, except for we're dealing with cat doses instead. So again, side effects are going to be similar to what we expected with our dogs with the benzodiazepines, sedation, maybe a little bit of ataxia. Paradoxical excitation, I think we see this more frequently in cats than we do dogs, but it can actually happen in both species. Behavioral disinhibition is another one that I want to talk about. And I don't think that I covered that when we were talking about behavior in dogs. And so behavioral disinhibition is basically not thinking twice about what you're going to do before you do it. So I analogize for owners or foster caregivers that it's like if you were thinking about dancing on the table, but you decided it wasn't a good idea, but after a couple of martinis it seemed like a really good idea. That's behavioral disinhibition. You have been disinhibited, so now you're not thinking twice about stopping that behavior. So we can see all sorts of crazy things pop up with this. And I think sometimes that's that excitation that's getting misinterpreted for that. But the thing about the behavioral disinhibition is I don't want to disinhibit a pet who's thinking about using aggression as a coping strategy. And so I pay attention to what the pet is doing when they are frightened in those situations. And if it is a pet that has been using aggression as a strategy, I might think twice about using a benzodiazepine in that situation, because I don't necessarily want them to think biting is a good strategy and get to that point quicker, or to perhaps lose some of their bite inhibition, perhaps bite harder if they do bite. So just a little caveat there. And again, that's a risk sensitivity issue that we're all going to be a little bit different on in terms of our comfort level with that. Gabapentin and trazodone can also be used in cats. As I mentioned previously, there has been a very nice publication or a couple of publications that have come out about using gabapentin prior to neurosurgery for community cats, and also one that came out using gabapentin prior to examination on transported cats. So a lot of good research is popping up with that, as well as trazodone. There's been some safety studies with that. But the thing with the trazodone doses are that you actually have to give it a minimum of 2 hours prior to the event if you're going to use it situationally, because it takes a little bit longer to take effect in cats than it does in dogs. So I'll tell dog caregivers give it 1 to 2 hours prior, but I'll tell cat caregivers give it 2 to 3 hours prior. So you want to make sure that's well on board before the stressful event starts to occur. But it can be very, very helpful as well. And I've had success hiding that in little bits of canned food or a treat, just as I have with the gabapentin. So another option to consider there for you, particularly if you have a shelter who's trying to limit the number of medications they have. They could potentially use something like that for both species. Okay, so again, another caveat for us to remember. Let's think about benzodiazepines given orally in cats. Remember that we had the case reports of the fatal idiosyncratic hepatic necrosis with Valium with those hospitalized cats. Remember, clinical signs were starting to appear 5 to 11 days after starting therapy, and oftentimes they progressed very quickly and were oftentimes fatal. So my rule of thumb is that this is an area where I don't compromise on getting some lab work prior to starting if we're going to be giving oral benzodiazepines on a regular basis. I check liver values before starting, and I require that they're checked 5 days after chronic dosing. And so generally what I will do is I won't give the caregiver more than 5 days worth of medication, so they can't continue the medication until they've gotten that lab work done. So again, there is a time and a place, and this can be very, very effective medications when we're managing behavior problems. We just have to be smart about how we're using them so that we're not putting anybody at risk when we do that, or at least minimizing risks involved. All right, so let's talk a little bit about the longer-term medications, and then we will move on here. So we're going to really focus on the antidepressants in this section here. So before we delve into these, I want to talk to you briefly about serotonin syndrome. I'm sure lots of you have heard about this, particularly via our public commercials that we get on TV about all the medications that are now available to us people. So essentially what serotonin syndrome is we have too much serotonin in the body. We've overdone it, right? We've reached toxic levels. We can see a variety or a spectrum of signs with this, anything from nausea and agitation all the way up to hypersalivation, seizures, coma, and death. Generally, this is going to occur when we combine an MAOI with another antidepressant, such as an SSRI or a TCA. That's the most common cause of serotonin syndrome. And essentially what happens when we do this combination is that we have an MAOI, which prevents breakdown of our neurotransmitters, added to a medication that enhances reuptake or inhibits reuptake. So we basically flood the synaptic space with excess levels of neurotransmitter. But we can see it in other situations too. If we have multiple MAOIs being combined together, this used to be more of a problem than I think it is now, because a lot of our other MAOI options are no longer available to us, or they're hard to get. So things like Amitraz, that might have been dip. I think we all knew when that was happening because you can smell it a mile away, right? Some of the tick collars, like to prevent tick collars, I do worry about that. Things like Promeris and Certifect, I don't think they're even on the market anymore. But we also have to think about supplements too. We could theoretically overdo it with supplements. So a lot of people say, oh, I want to go the natural route, so let's give tryptophan instead of a medication, right, because it's safer. Or the over-the-counter herbal supplements like St. John's wort. St. John's wort actually works like an MAOI in the body. So we actually have to be pretty careful with that, because that can be a potential cause for serotonin syndrome, particularly in our pets when we're dealing with a smaller body size with those supplements. Another one that I worry about quite a bit is Griffonia seed extract, or also known as 5-HTP. So this is a precursor to serotonin, and it's actually quite potent. And there have been some case reports of a dog eating 1 to 2 capsules and actually getting serotonin syndrome simply just from the supplement itself. So I actually didn't even think it was available to people anymore because of the risk. But I recently had a client come in to see me who was giving her pet over-the-counter graphonia seed extract, and I had a little bit of a moment, and we talked about how dangerous that is. So it is still floating out there, so make sure you're doing your due diligence in terms of looking at supplements that people might be giving as well. There might be some risk of combining multiple serotonin medications. I think we read about this and hear a lot about it. Oh my gosh, don't put trazodone together with another serotonin medication. Or what about tramadol, things like that. Theoretically, it could happen, but I think there's a lower risk with these medications. And my general rule is that I don't do more than 2 serotonin medications together at the same time. And I start at the low end of dose ranges for both of them, and I increase as needed. And rarely, if ever, am I going to go to the max end of the dose ranges for both medications at the same time. And so remember, tramadol does have some serotonin effect as well. So that's going to be included in our medication list when we're thinking about our serotonin medications. And this actually brings us to our next table here. So we're going to talk about our SSRIs. So these are our most common ones that we're going to see, and probably the ones you're most familiar with. So our fluoxetine or Prozac, or our sertraline and Zoloft. You can see our dose ranges there, 1 to 2 milligrams per kilogram once a day for our Prozac, or up to 4 milligrams per kilogram every 24 hours, or you can divide that to twice-a-day dosing for the sertraline. I generally expect to see maybe a little bit of drop in appetite, maybe a little bit of lethargy initially when we start these. Those tend to be mild, and they tend to go away on their own within 1 to 2 weeks. And I tell folks, whether it be a caregiver monitoring this pet, my designated point person, or an owner, that if you see anything beyond that, it's unacceptable, and I need to know about it because we need to adjust the dose or adjust our medication. So any type of GI upset, vomiting, diarrhea, agitation, increased irritability, increased anxiety, those are all things that we need to know about. So that's a list of what I give my monitoring person to watch for when we start these medications. And I will say that the side effect profile for trazodone is quite similar to the SSRIs. So oftentimes if I'm using those 2 medication classes in a shelter, I will give them one list of side effects to watch for to contact me about for any of the medications they're using. All right, so let's move on to our poll question now that we're in the midst of talking about our serotonin syndrome, our serotonin medications.
Okay, so for our third poll question, we have, who is afraid of serotonin syndrome? And your answers are A, I am. I don't want to accidentally kill my patient. B, I'm aware but not overly concerned as long as I check my doses. Or C, I am not worried about this. I think it is really a phenomenon in people. Okay, so I'll give you a little bit more time to answer the question. And just remember that if you have any questions for Dr. Bennett to ask them in your Q&A box on the left side of your screen. Okay, so here is our answers, and again, we have a unanimous answer, Dr. Bennett.
Awesome. I am aware but not overly concerned as long as I check my doses. That means I didn't scare you too much with my little spiel for serotonin syndrome. Fantastic. That's where I'm hoping that you will be. I mean, it is something that we have to be aware of and think about, but I don't want it to be something that's going to keep you up at night or you're worried about using these medications in your patients because of this risk. So as long as we're smart about it, I think we can use them effectively and avoid this as a risk. Okay, so let's go back into our medication choices. So let's talk about the other antidepressant classes, so our TCAs and our zaparones. So you'll be familiar with our TCAs because that's where clomicalm falls in. Remember, clomicalm is our medication that's FDA approved for the treatment of separation anxiety in dogs, along with a behavior problem. You'll see that the dose range that's labeled for clomicalm is 2 to 4 milligrams per kilogram once a day. But I will tell you that most behaviorists are going to actually use this twice a day because we get better efficacy and success with our treatment plans. So you'll see the twice-a-day dosing below there. So essentially, most of us are using Clomicalm off-label, even if we're treating separation anxiety in dogs, because we are asking our caregivers to dose twice a day. We might see a little bit more stomach upset with this class of medication. We might see some more anticholinergic effects. We'll talk about why in just a second. But this can be a really, really helpful medication for us because sometimes we can take advantage of those side effects. So Clomicalm might have a little bit more lethargy or what some folks like to call behavioral calming effect. But I find that most of the time when I use this that it's actually something that's temporary and gives the caregiver a little bit of a respite from the over activity of the patient for a couple of days to a week or so. But the reason it has these effects is because it's actually working at different neurotransmitters. We'll look at a table that will explain that a little bit more in just a second. Buspirone can be another one that can be really helpful. Alone, this medication isn't going to be very helpful for panic, but it can help with anxiety, generalized anxiety. And I think a lot of us are actually using this in conjunction with other antidepressants, so combining it with something like fluoxetine. So our 2 serotonin medication rule would play in here, but it can be another good medication for us to use. It does take at least 6 to 8 weeks to see the effect, and generally we need to dose it twice a day, sometimes 3 times a day. So it's not going to be appropriate for every pet, but it can certainly be quite helpful. And one of the best things about this medication is that it's actually very specific for the serotonin 1A receptor. So side effects are pretty much minimal to non-existent for it because we're bypassing all those other receptor sites that we looked at when we were looking at the table of all the places where serotonin can act in the body. And we're avoiding all of the GI receptors, all the receptors associated with nausea and vomiting and things like that. So perhaps a safer choice than some of our more sensitive patients or our older geriatric patients. So going back to the TCAs and why I was saying that maybe we can take advantage of some of the side effects of those medications, the TCAs are actually what you might consider a dirty drug. So rather than being very specific for one receptor, such as the SSRIs with serotonin, these can actually work at a lot of different receptors. So you'll see here in this table the relative effect at different receptor types or neurotransmitter sites for specific TCAs. So clomipramine, the one that we're most familiar with, the one we use most often, you'll see has a lot of activity of serotonin, right? That second tier there, 5-HT. But it can also have some muscarinic and alpha-1 effects, and those are going to be the reason that we'll see some of the anticholinergic effects, right? So, for example, if I had a pet who was having anxiety-related urination issues, perhaps I would want to take advantage of clomipramine because maybe we're going to have a little bit more likelihood of urine retention or something like that. You'll see on here amitriptyline, one that's historically been used for cats who are urine marking outside the litter box, actually doesn't have that much serotonin activity, but it has a lot of histamine and muscarinic activity. So I think a lot of times the improvement that we see with this medication on board for these cats is actually due to pain control, neuropathic pain control, because we're activating some of these other receptors. Doxapen, one of the dermatologists that I trained with during my residency loved to use doxapen because you can see here it has a lot of histamine control. And it also has a little bit of norepinephrine, a little bit of our alpha effects here. So she would use it mainly for the antihistamine effect, but she'd also use it to help try to take some of that anxiety and irritability edge off her patients who were so agitated because they were so uncomfortable because they were so itchy. So again, thinking about how we might use these medications and side effects and some of their other activities to our advantage. So this table can be really, really helpful when we're thinking about that. All right, then we have our table for cats as well, just as we did with our short-term acting medications. Again, we can use same types of medications. Here, SSRIs here, fluoxetine or paroxetine, which is Paxil. Note that the doses for cats are much lower than the doses that we had for dogs. So my fluoxetine dose is essentially half of what my dog dose would be. And we're only dosing once a day for these medications. With paroxetine, you might see a little more likelihood of urine retention or constipation. And I do tell caregivers to really watch the appetite with these cats with this, because the appetite drop in a cat concerns me more than appetite drop in a dog. I don't want to push these already stressed cats into a state where they start to develop something like hepatic lipidosis. So make sure that they're watching how much that cat is eating when we start these medications. Buspirone can be a really helpful option for our cats as well. We don't have to dose it quite as frequently for cats as we do for dogs. And the tablet size can be quite conducive to getting in cats. And of course, side effects being low, I always laugh when I read this, though. And one of the reported side effects for cats was actually increased friendliness. And I thought, gosh, that's a side effect that perhaps maybe we want to take advantage of more frequently. But another one, too, particularly when we're looking at intercat social interactions, is that perhaps the cat might be a little assertive, too. So sometimes we can have some increased conflict from that. But can be a very, very nice option for us also. Okay. And moving away from our specific medications, I want to focus now a little bit more on the shelter aspect of it and thinking about outcomes and how we think about how we're going to use our medications and making a plan for them for the essential goal of why we're doing all of this is to get this pet out of the shelter, right? So let's talk a little bit more about community perception and organization perception and some of the things that we have to keep in mind when we're putting together our long-term plan for these pets. Remember, I mentioned that some communities are going to feel differently about medications being used for behavior problems than others. And this was actually very clearly brought home to me when I was working in the Chicago area during my residency with a couple of sheltering organizations that were quite enthusiastic about using behavior medications as part of their plan. And they didn't feel that it was a barrier to these pets being adopted, because a lot of folks in the Chicago area were, in fact, taking these medications for their own mental health. And so everybody there was kind of, quite open to the idea, better living through chemistry, certainly an option that I'm willing to consider for my pet because it's an option I consider for myself. And I went to Boston and did a course there at one of the organizations, and we were talking about behavior plans, and I asked about medications, like, oh, well, we actually don't use those as often as perhaps we would like to, because we've found that this can be a barrier for these pets to become adopted. So the potential adopters are turned off by the fact that we're using medication, and there's still quite a bit of stigma associated with that. And then maybe perhaps you look at an area like Austin, Texas, right, where everyone wants everything to be more natural, in parentheses, of course. And so they're more willing to go the supplement route rather than perhaps using a medication or a synthesized drug. So it helps to know your community and what the perceptions and stigma levels are there and what the preferences are in terms of whether or not we want to use medication, and if we do, what ones might we choose. Not only can we have that be a problem perhaps or a roadblock for us in our community, it can also be a roadblock in our organization, right? So there are some organizations that are quite willing to be open to trying new things with their treatment plans. Others that have, very strong thoughts that perhaps the pets that are experiencing behavior problems while being sheltered is really a consequence of that sheltering organization themselves, and not necessarily a neurochemical imbalance with that pet. So again, I think there's always a balancing act with this in terms of let's not rely too heavily on medications to make up for our deficits in the environment and things that we can change, but certainly recognizing that there is going to be a population coming into our organizations that does have some degree of underlying behavior pathology that we're not necessarily going to be able to address completely with just environmental management. So that's where our conversations and our respectful discussions can start to really be helpful for us to help educate those around us and those groups that we may be working with. Another thing that we want to think about is upon outcome, so leaving the shelter, does the veterinarian who is in charge of that pet have to speak directly to the next party involved with caring for that pet? And this is going to really depend on where you are as to whether the veterinarian has to be intimately involved with that discussion or whether that can be relayed by another professional within the organization. So something to think about in terms of your organization and the amount of work and responsibility that you're asking of your veterinarian who's doing the prescribing. Follow-up. Who's going to follow up with this pet after it has left the organization? You know, whether it's going to transfer to another organization or it's being adopted. What's our plan, right? We're using medication, so there's got to be a veterinarian involved in terms of what to do after the pet's moved to the next step. So is it going to be your veterinarian? Are you going to refer that to another veterinarian? And the same thing goes with the organization, right? How's the organization follow up with that? So what do we do in cases of noncompliance? Let's talk a little bit more about these. The things that you might hear these from organizations, you might hear these from adopters, right? Oh, I don't want to adopt that dog because you're just sedating him, right? You're just masking the symptoms of the problem, and as soon as he gets out of here, he's going to be different than what he was, and I can love the anxiety and the fear out of him. He doesn't need medication, and just needs to get out of the shelter, right? Or perhaps he's going to be addicted, right? Or it'll decrease his adoptability. All of these are things that we're going to hear as potential roadblocks to use medications. And so again, this is an opportunity for us to really take a step back and have the opportunity to discuss with the next party involved what exactly we're trying to do with these medications. We're not sedating them. We're not masking the symptoms. We're trying to help that normal dog come out more, right, and manage the situation with as many options and our tools that we have available for us. So we have to think about this when we're putting our plan together. So who's going to do the adoption counseling, or let the next group know what's happening, right? Again, this might vary from state to state, as I said when we were talking about whether the veterinarian has to be involved or not. We want to make sure we have a plan that goes with that pet. I mentioned that I do this with all of the pets that I evaluate for behavior. Each one of them is going to have a plan that follows them through till their final outcome disposition. That's going to include medications and what to expect, but also environmental management and things like that, and behavior modifications. So we can set that pet up for success on the next step of his road. Full disclosure. Full disclosure really needs to be a requirement. If we're going to be managing pets with behavior problems, regardless of whether we're using medications or not, we need to have the expectation that we are getting all of the information that we have available to the next party involved. It is irresponsible and unethical for us to withhold information that we have about the pet to the next party because we're afraid of the stigma that might be associated with it. We need to give them all of the information, let them make the decision on how to proceed based on that information. And we also want to make sure that we've got some recommendations of who the next group should follow up with, right? Do you have specific veterinarians in the area who are more well-versed in behavior medications? That might be a good next step for this person who's caring for this pet. Or a qualified training group that you trust to continue your plan through the next step. Or do you want them to come back to you at the shelter for follow-up? That's certainly an option as well. Adoption versus transfer. Obviously, with adoption, we need to make sure that the new owner is educated about the medication. Why are we giving it? How to give it? What to watch for? Who to follow up with? We talked about some of those steps already. Then a plan. Are we expecting that this pet's going to need to continue medication, or do we think we can wean it down fairly quickly, after that transition period? Again, in a perfect world, if I ruled the world, which I know I don't, but if I did, all of the pets who get adopted out would stay on their medication for a month. so that they have the opportunity to transition into that home and become acclimated with the family members and the new schedule, and then we will wean them down. That doesn't always happen, but that is my goal and what I generally recommend. But we have to make sure that the owner understands why we're doing this and the risk of stopping medication abruptly. So, and some organizations may consider weaning the medication off before they adopt the pet, so that that's not a part of something that they're asking the next party to do. Same thing goes when we're thinking about transferring to another organization, right? Whether it be a shelter, a rescue group, foster, etc. What's their philosophy and policy with medications? We talked about that perception difference that can occur. So we want to know how they feel about it before we send the pet off with the medications. Maybe we want to talk to them about, we started this and why, and what our expectation is for how long it would be, or perhaps this is a situation too where we might want to wean before transfer. Or we may consider using a short-term medication, one that acts quickly, so that we can help the pet while he's in our care, and then let the next party make the decision based on their environment as to what we use. So lots of different things for us to think about from that perspective. So to wrap things up, just to remind you, there's several uses for behavioral medications in shelter medicine, but we have to make sure that we're thinking about having a treatment goal, doing a risk assessment, and looking at the quality of life and resources available before we decide to add behavior medication to our plan, and which medication to add to our plan. Obviously, the shelter is a little bit more of a unique environment than perhaps most of our privately owned pets are going to be in. We have to think about cost and availability, frequency and route, how long it takes to affect, and abuse potential when we think about what we're going to choose. And then, of course, along with our medication plan, we have to have a monitoring, follow-up, and post-outcome management plan as well. And so with that, I want to thank you very much for your time this evening. And I'm going to hand it back over. I think we may have a few minutes for questions.
Yes, we do. Thanks so much, Dr. Bennett. We're going to start with our first question now. If behavioral modification is not available in the shelter environment and the animal cannot go into foster care, for example, it's a protective custody case or bite quarantine case, is medication still reasonable if the underlying issue cannot be addressed?
This is a really great question, and one that we actually encounter pretty frequently. And I would say that behavior modification is always available. It may not be fancy and elaborate, but there's always something that we can do. And so it may be as simple as strategic housing. Can we put that pet who's reacting to every single one that passes by in a quieter area or at the end of the kennel run instead of the front of the kennel run? Can we do something as simple as quiet kennel exercise or treat buckets so that we're at least taking advantage of some classical conditioning for that pet, or foraging toys, things like that. So there's lots of little things that we can do that can actually have a really big impact that are still going to be included in the category of behavior modification. So we still can do things like that along with that. And that is absolutely a situation where I would consider using behavior medication. And I would actually consider for those cases they tend to have longer lengths of stay, using short-term medication to address the problem that's occurring right now, and then layer a longer-acting medication on top of that, knowing that that pet's going to be in our care for quite some time.
Okay, great. Thank you. Our next question is, a common concern is if behavior medication in a shelter will mask aggressive behavior that will surface after adoption when the medication is discontinued. Do you think this is a valid concern?
That's an interesting question in terms of masking aggressive behavior. And I think this is where we really have to make sure that we are doing our job as veterinarians to have a examination and reviewing all of the information we have available and making a working diagnosis for this pet. Most of the time, aggression is a consequence of fear and anxiety or some type of negative emotional state. And so if the shelter is comfortable trying to manage a pet who is using aggression as a coping strategy, we need to have a diagnosis underlying that, and we need to be addressing the underlying anxiety and fear that's causing that pet to react in that manner. And so it's not masking aggressive behavior, but it's actually treating the underlying emotional state associated with it. And so I think if we describe to people exactly what our goals are of using medication and are very clear with the next party involved, that, this pet has a behavioral diagnosis of fear aggression or territorial aggression or something like that, and that we are managing it by, avoiding this situation, which is a trigger for this pet, and using this behavior technique to give him an alternate strategy. And also we're using medication to try to address his underlying anxiety. That helps us circumvent that myth that we're masking aggressive behavior and that it's going to reoccur in the new home. It may or may not occur in the new home. It may have been a consequence of the environment the pet was in previously. That pet may or may not need to have the medication continued in the new home. And that's where it's going to be very important for us to make sure that we have a plan for follow-up, that we have documented in our records, and we say, we gave this pet this medication to go into the new adoptive home. We told them that we need to have follow-up within a month before we talk about whether medication is going to be weaned down or not, so that we have a plan for that pet to make sure that he's on the best pathway for care after he moves to the next party. So hopefully that answered that question. But I think that's where these steps in terms of making sure we've got a plan all the way through can be really helpful.
Great, thank you. What are your thoughts on supplements such as Zilkine, Composure, Angstane, etc.?
So I actually like a lot of those supplements. I use them in my own pets and in my privately owned patient population as well. Some of the shelters that I work with are willing to use these for the pets in their care also, though when we're looking at it from a shelter aspect, a lot of times the costs can be prohibitive for many of the organizations that are on a bit of a tight budget. I think some of our medications are much less expensive. However, if we have the ability to take that expense and we have a pet who's particularly challenging to medicate, sometimes the supplements can be a little bit easier to get into them. The other thing I will say is that a lot of times the supplements aren't going to be enough for a profound level of anxiety or behavior pathology. They can be quite helpful for mild or moderate anxiety, but the severe ones, these alone aren't going to be enough. But certainly another thing to have in our toolbox, depending on the organization that you're working with.
Especially in your Austin natural areas, right?
Yes, exactly, right.
Okay. How long can one use the fast-acting medications? Could you use a fast-acting medication while starting a long-term medication to help decrease anxiety more quickly?
So yeah, the thing with the fast-acting medications is looking at our goals. What are we trying to do? So if we're trying to reduce anxiety right now, we're going to want to use one of our fast-acting medications. So what's the next step, right? What's our long-term outlook for this pet? Are we doing this because we think this pet's going to have a relatively short length of stay in this situation, and we can change the environment enough that we can address what's causing them anxiety and stress so that that doesn't occur? If so, we might just need to use that fast-acting medication in and of itself. However, if we can't get that pet out of that situation, we can't change the environment, we can't modify what's stressing them out, we can't move them to another home such as a foster or a different part of our shelter, then maybe then we want to consider adding in our long-term medication. And I do actually layer these quite frequently. when we have those situations. So I'll start my fast-acting medication now to try to get that pet some immediate relief. And then in about a week or so, if that pet is still in that situation or still experiencing that stressor, I'll add in my long-term medication. I'll keep my fast-acting medication on board until I think my long-acting medication has had enough time to work. So that usually that 6-week window is we're going to reassess and determine whether or not we think that fast-acting medication needs to stay on board. And that's one of the reasons I actually really like to use trazodone, because I think we can see a little bit of a synergistic anxiety effect when we combine that with an antidepressant. So that can be really helpful for us. And I will say with the benzodiazepines, we can actually get dependence and withdrawal signs with that if we're getting it every day for longer than a month. So that's one in particular that I pay attention to how long the pet has been receiving it. And if he's been receiving it for longer than a month, I do have to be very careful about weaning it down slowly so they don't have withdrawal side effects.
So our next question is a great follow-up to that then. This one is about benzodiazepine using cats. Is the concern about that for chronic daily therapy only? How about intermittent or short-term therapy? Is that a problem?
So the benzodiazepine concern for cats with the idiosyncratic hepatic necrosis, that is for chronic oral daily therapy. So I would consider anything more than 5 days to fall into that chronic category. So if you're doing it intermittently or if you're doing it less than 5 days, I am much less worried about the liver aspect of that medication. But if you think that you might have to use it longer than 5 days every day, that's when I start to be concerned about it. And this really is a cat-specific problem. We haven't necessarily seen this documented in dogs, but I will say even in the cats who are done well with it and aren't having liver side effects, we do still want to make sure that we're weaning gradually if they've been taking it every day for longer than a month.
Our next question is going to be our last question, and this one is, what have you experienced as a challenge as far as explaining medication to adopters?
This is a great question, too. I would say the most common challenge that we have is that the adopter expects that putting the pet into their home and being loved by them is going to be enough to replace the effect of the medication. And so the pet will come out of the shelter or the rescue group on medication. We have the problem managed, and we say we need to keep these medications on board for a month, and then we'll talk in a month and see how the pet is doing, and we'll talk about a long-term plan, whether we need to keep these meds on board or adjust them based on how he's doing. And they say, oh, that sounds great. And they get home and they say, oh, honey, it's okay. I know that place was so scary. It's all okay now. We love you here. We'll never hurt you. We don't need these silly pills. And they stop the medication abruptly, within a week of coming home. Luckily, many pets actually do really well with that, even though it's certainly not what we recommend. But inevitably, we will have a subset of these folks who will call us within a couple of weeks and say, hey, those meds that you gave us to give, we stopped giving them, or we ran out and we didn't follow up the way you told us to, and we're having problems now. So that opens up the window for us to say, okay, well, let's talk about what's going on. Do we need to have you come in for an appointment? Let's tell me what you're seeing happening so we can get everybody back on track. And most of the time I find that we are able to get them back on track, getting the medications back on board, getting the management plan set up in that home so that the pet can stay there and get things moving in the right direction. I think some people just don't believe us that the medication actually does something, and they think that they truly can just love the problem out of the dog, which unfortunately we know isn't always possible. But I think as long as we're open with them and not confrontational and we don't scold them, they're willing to be a part of it, because oftentimes I find that they've started to bond with that pet by then, so they're willing to put in a little bit extra work.
Thank you, Dr. Bennett. With that answer, we are going to be ending our event tonight. I want to thank all of you for your time tonight, and a special thank you to Dr. Bennett for an amazing presentation. Before I launch into a few closing remarks, I would like to ask all of you to click on the evaluation survey link on your screen and give us your feedback. While you do that, don't forget to mark your calendars on December 14th for our next webcast on creating a barn cat program. For more information and to register, go to our website at www.maddiesinstitute.org. This webcast will be available on demand shortly, and we hope you will share this presentation on your social media sites. Thanks again for being here with us this evening, and good night.